Yeah, good evening, everyone. So my name is Kenya Kusunose, and I am a professor of University of the Ryukyu in Japan. So I'm excited to have the opportunity to talk about artificial intelligence. AI is not only the future of technology, but also becoming a fundamental part of our daily echocardiographic practice. There are my disclosure. My talk will be divided into three main parts. First, I will give you a brief overview of the basics of AI. Second, I will discuss how we can use AI in echocardiography. Finally, I will share some thoughts on the future direction of this technology. First, let's start to introduce the basics of AI. The main component is the technology for data analysis. This involves various methods for interpreting large data to abstract meaningful insights. Artificial intelligence is a technique that allows machines to act like humans. Machine learning is a subset of artificial intelligence. It allows the machines to learn and make predictions based on data. Deep learning is a subset of machine learning that focuses on algorithms inspired by the structures and function of the brain, called artificial neural networks. When we train AI to recognize images, conventional AI needs an expert to check the points of interest and extract features. This method sometimes makes some errors. On the other hand, deep learning, a new type of AI, does not require the knowledge of an expert and handcrafted feature extraction. The machine automatically extracts and learns the features, resulting in much higher accuracy. Next, I introduce the tasks of AI. Types of learning with artificial intelligence can be classified into three categories: supervised learning, unsupervised learning, and reinforcement learning. Today, we focused on the supervised learning in this presentation. Supervised learning is a method of learning by labeling training data with the correct answers. The features are extracted and grouped based on the labels. For example, some pictures have a dog label and others have an apple label. The algorithm learns by analyzing the features of each image and associating them with the corresponding label. After the training process is complete, the machine will analyze a new image and make a prediction, telling us whether it is the image is of the dog or an apple. How about we think about the idea with echo images? First, we gathered many echo images. Experts label these images based on their knowledge, like normal or abnormal. The computer then studies these images and learns the differences between a normal heart and an abnormal heart. When we present a new unlabeled echo image to the training machine, it examines the image and predicts the presence of cardiac disease. Let's start to talk about the utility of AI. Why do we want to make AI for echocardiography? Because there is clinical variation in this field. For example, if we go to two doctors, they might have different opinions about the same echocardiographic images. This happens at every stage for the interpretation of the images. Reliability and accuracy are separate aspects of echocardiographic measurements. Shooting at a target is an example to clarify the definition of reliability and accuracy. This figure shows the combinations by reliability and accuracy. For example, If you always miss a target in the same way, you are consistent but not right. To overcome this issue, AI may be useful. In this solution, I would like to talk about LVEF. Despite the recent advances in echocardiography, left ventricular ejection fraction is still the most important index of systolic function in daily practice. Several methods, including M-mode, V-mode, and three-dimensional echocardiography, have been proposed to measure LVEF. However, LVEF calculated by these methods has poor inter-observer reproducibility, depending on the observer scale. In this slide, we show the comparison of advantages between different methods for measurement of LVEF. The most common quantitative method is the biplane disk summation method using a V mode. Three-dimensional method, though, is one of the great methods to assess the LVEF because of high reproducibility and independent of geometric assumptions. However, the availability and speed depend on the massing power. Importantly, in the daily practice, visual estimation of LVEF is widely used to confirm quantitative EF. To check the reproducibility of visual estimation of LVEF, we designed the multi-center study in 2018. In this study, we compared the eyeball LVEF and biplane disk summation method in each institute to check the difference among 13 cardiovascular institutes. Our findings shows that the eyeball LVEF was different at each place. 5 out of 13 places had a big differences, more than 5% in the LVEF. Thus, even in the expert cardiovascular centers, the LVEF assessment should be standardized in the clinical practice. Let's talk about what AI can do for us in the future. I think there are two big things to consider. First, can AI do things faster or more accurately than us? The answer is often yes. For example, AI can quickly check lots of information and find what's important. Second, let's think about this, that are hard for people, but might be easier for AI. Can AI notice tiny details that even experts might miss? There are a lot of promise here, and researchers are excited about that might be possible. Several years ago, we published one of the first AI models for left ventricular ejection fraction. Automated LVEF is a key for improvement of reliability and accuracy. Previously, when the conventional AI automatically measured the LVEF, it was necessary to learn the location of the heart and endocardial borders. Unfortunately, there are some errors on the detection of location. On the other hand, using deep learning, the new AI directly estimates the LVEF without tracking the endocardial borders. People learn to estimate EF by looking, and AI is learning to do the same. In deep learning, all features extraction steps are built in the algorithm, so it can learn by itself from beginning to the end. In this study, we trained a deep learning algorithm could estimate LVEF and differentiate preserved EF or reduced EF independently volume. In order to develop and train the model to volume independently estimate LVEF, we used a dataset of 340 echocardiographic studies. The total number of images is 17,000. This slide shows the correlation between expert LVEF and deep learning EF. Deep learning EF is a good agreement with expert EF. R value is 0.92. This slide shows the classification accuracy of preserved EF and reduced EF. Cutoff value is 15%. Generally, LVEF can be calculated using only two-chamber and four-chamber views. But in daily clinical practice, the observer should check the other echocardiographic views. Therefore, it is expected the accuracy of LVEF can be improved by additional views. In our results, the model based on 5 views was the highest accuracy. Next, we would like to see how this could be useful in real clinical setting. We got 5 people with basic level 1 skills from 5 places. First, they estimated the LVEF value. Then, we showed them an AI LVEF on the same screen and asked what they thought about it. This slide shows the reliability and accuracy of LVEF as assessed by 5 level 1 echocardiographic readers from the first and second session. For the first session, the standard deviation for the reliability of LVEF was 6.1 and RSME for the accuracy was 7.5. With the AI LVEF included for assistance with a read. The SD and RMSE was significantly improved in the second session. These results suggested that displaying the assessment by AI LVEF on the screen improved the concordance of level 1 readers from different institutes. Next, I'd like to introduce a software developed by Astro AI from the United States company for automatically measured DICOM data. Here's a demo image. Clicking on a case from the list will bring up an automatically analyzed screen. AI measurements are performed automatically, and the results are displayed on the screen. If you scroll down to the bottom of the screen, you will also see a measurement for Doppler waveforms. And clicking on this will clarify where the measurements were taken. Additionally, you have the option to manually adjust the measurement location using the image. The software is capable of not only measuring Doppler waveforms, but also automatically measuring other parameters like left ventricular volumes. The accuracy of this software has been validated in 2022 from the United States group, which shows the relatively high correlation coefficient. As a result, it is used as a clinically valuable tool in echocardiographic field. In Japan, our group plans a new study for this software. This study aimed to compare the accuracy of strain measurements between fully automated software and human experts. A total of 150 patients were included in this study. Echocardiographic parameters were independently assessed by human experts and the fully automated software. This is an example of a global longitudinal strain and left atrial strain measurements by human experts and AI. For the strain measurement, the software demonstrates robust performance with correlation coefficient for the left ventricular global longitudinal strain and left atrial strain of 0.84 and 0.77. Next, we plan to compare the time taken for measurement by AI to that by human experts. 23 consecutive patients were examined by a single operator. These patients had different healthcare conditions and image quality. We checked how much time was needed to measure the echo images and write reports. As a result, the AI significantly reduced the measurement time compared to the manual method. The incorporation of AI into echocardiographic analysis led to a 70% reduction in measurement time compared to manual methods. In the other advantages of AI in echocardiography, we made an AI model to detect regional wall motion abnormality in echocardiographic images. The evaluation of regional wall motion abnormality has been traditionally subjective and relies on visual adjustment using endocardial motion and myocardial thickness. Thus, a useful objective method has long been desired. In this study, we focused on the short axis images because we can diagnose three coronary territories using one axis. The aim of this study was to evaluate whether a deep learning could detect regional wall motion abnormalities compared with cardiologists, sonographer, and resident readers. A total 300 patients with history of myocardial infarction were enrolled. In this study, 100 each had infarctions of the LAD, LCX, and RCA, and the age-matched 100 control patients were included. For the detection of the presence of regional wall motion abnormalities, the AUC of deep learning algorithm was similar to that an experienced cardiologist or sonographer, 0.97 vs 0.95. The AUC of AI was significantly higher than the AUC of resident physicians, 0.97 vs 0.83. Finally, I'd like to talk about the future of AI, focusing on several key areas. First, there is a device known as a wearable cardiac ultrasound imagers, which paste echo patches to visualize the heart. The last year academic papers, the image quality from the device is comparable to commercial version. Advanced segmentation technologies enable us to measure the areas of left and right ventricle automatically. In the future, I think we could just put on the sticker and see echo images. It seems like a world where measurements come easy is coming. The next stage in AI is generative AI. A prime example is ChatGPT, a chatbot developed by OpenAI, released in November 2022. Its ability to generate detailed answers to a wide range of questions reaches the passing grade after solving questions on the U.S. National Medical Examinations. There have been studies, such as the one from Cleveland Clinic, evaluating the effectiveness of popular AI tools among cardiologists. They test whether ChatGPT could accurately answer to 25 questions related to cardiovascular disease. Answer 21 of the 25 questions appropriately. Reasons for errors included incorrect LDL cholesterol cutoff levels, lack of genetic consideration for family history, and other information that is not commercially available. Our group has also conducted research using the Japanese hypertension guidelines to test the AI's capability in answering clinical relevant questions. While the AI answered an 80% accuracy rate in answering clinical questions, it was less reliable when faced with questions which is not based on the Japanese experts' discussion. Thus, there are some limitations of ChatGPT. In a report published last years, the ability of GPT-4 to support diagnosis was investigated using a clinical pathological cases conference. published in the New England Journal of Medicine for educational purpose. 70 CPCs were evaluated, and in 27 cases, GPT-4 were completely consistent with the final diagnosis of CPC. In addition, in 64% of cases, the final CPC diagnosis was included in the GPT-4 differential list. Chatbot cannot replace the expertise and experiments of trained medical professionals, but generative AI has promising potential as a human aid in diagnosis. From these observations, I believe that ChatGPT could serve as a future tool for generating medical reports. I have recently published a review on this topic in Japanese in the Journal of Echocardiography. This is a Japanese official journal. If you are interested, please feel free to read it. In conclusion, AI can incorporate it into everyday practice and become a valuable aid for many healthcare professions dealing with cardiovascular diseases. In the near future, it will be necessary for cardiologists to incorporating this new horizon of artificial intelligence in echocardiography into their daily practice. Thank you for the attention.